Welcome to the 4th Annual Dry Eye Center of Excellence Symposium, sponsored by Pentavision and Ophthalmology Management. Special thanks to Lauren Levine and Doug Perry for putting this monstrous endeavor together. And a special thanks to all of our sponsors who have been so instrumental in producing this synergy of so many talents, so many diagnostics, so many therapeutics that we all believe will grow our practice in the future. We have an illustrious panel of presenters here today, and I want to give you an overall view from a management perspective. As the managing senior partner in our practice of 17 doctors with 200 employees in 7 locations, we focus on cataract and refractive surgery. We focus on ocular surface disease. We focus on glaucoma. We focus on posterior segment disease. But we find that there's a common thread because virtually any patient can develop ocular surface disease. As a matter of fact, in one survey in the PHACO study, 80% of patients presenting for cataract surgery had evidence of dry eye, and yet only 20% of them had actually been diagnosed. So we emphasize ocular surface disease in our practice and have created a dry eye center of excellence. So what's the big picture? There's decreased reimbursements, burgeoning demographics with fewer providers, regulatory expansion, and stable interest rates. We need to invest in ocular surface disease. And do we have a choice? No. If you want to deliver state-of-the-art care, you must have the ability to address dry eye disease. There's 100 different names. Stick with dry eye disease because that's what all of the providers, all of the referrers, and all of the patients, most importantly, really understand. And there's this overlap of so many ocular surface diseases that we will use collectively here. And we look upon dry eye as just as important to our practice in our publicity, internal and external, to the public and to our referral sources. So there may be some objections, but we'll look at ways to expand procedures, product lines, and practice growth in the bottom line. And you can get a Dry Eye Center of Excellence certification from the folks at TearLab. So does this slow you down? No. Use a physician extender. If you want to be a surgeon, have somebody medically or optometrically handle the ocular surface disease in your practice. Use these valuable people to make your time as a surgeon more valuable. After all, we've only educated 500 ophthalmologists per year for the last 2 decades, and the Medicare population is doubling. So we also see that in PKP, LASIK, glaucoma surgery, blepharoplasty populations, dry eye is prevalent, and we know that better surgical results and predictability are dependent upon management of the ocular surface. So we have zero tolerance for any signs of inflammation, surface irregularity, or dry eye, especially in the context of a multifocal lens patient where they can become very angry if you don't hit your metrics. Beware of the ocular surface. So any type of surgery impacts dry eye. Cataract surgery will add 1 DU's severity level to your patient, and LASIK surgery will add 2. So plan appropriately before these surgeries. Tell them they have dry eye so you're not the cause when you subject them to the scalpel or the laser. So how can we expand procedures to our patients and our practice's benefit? Punctal plugs are often ignored. They are extremely useful for short-term and rapid results in those patients who may doubt your ability to bring them the result that they seek. And we can produce some very reasonable income with both permanent and temporary punctal occlusions. We've drifted towards the dissolving plugs because there's fewer callbacks. You can renew them every 6 months now. We're very fond of the various types of techniques to improve the meibomian gland physiology. And we certainly have enjoyed growth in our thermal pulsation practice, which must be dealt with as a premium practice with consultants and counselors and all sorts of payment plans that will bring this to the largest public. And we've seen our usage double since the price was cut in half by Tear Science. So we look at retail collections, and we can do very well in this particular practice, and you must trace this. You must have a good financial manager watching these sales for you to make sure that what you're doing is benefiting the practice and not creating excess inventory. So we use myeyestore.com, and it's an incredibly useful way to reduce the overhead in your practice for getting these products to patients that you recommend. Our biggest sellers are Avenova lid scrubs. The hypochlorous acid truly sterilizes and preserves the inflammatory milieu in the ocular microbiome. And hydro-eye and nutritionals are very big sellers as well, popular with patients. But in some of the more recalcitrant cases where severe ocular surface disease inhibits clarity of that central visual axis despite what you might call maximal medical therapy, we use the Procara, or the cryopreserved sutureless amniotic membrane. This is expedient, it's an adjunctive, it can give you rapid results in normalizing that central ocular surface refractive surface. This is taken from the amniotic membrane. There are multitudes of growth factors and antimicrobial factors and all sorts of anti-inflammatory proteins that allow this cryopreserved protein delivery system to remain potent throughout the shipping and processing. And this is attached to a flexible ring. It's fairly comfortable, and it imparts a wide variety of advantages over a standard bandage contact lens, which we use all the time in our practice. And because of these growth factors, you can rapidly accelerate normalization of the surface. In fact, in a study we did of 40 patients, we saw a 95% improvement in fluorescein staining, 85% improvement in symptoms, and a wide variety of benefits, including normalization of MMP9 expression and irregular surface topography. So in a patient like this with basement membrane dystrophy, previous laser surgery, and a dry eye, we look at preoperatively higher order aberrations are off the mark, and we see certain irregular keratometric readings. We place the Procara, and we see that there was a tremendous reduction in the coma, as well as a change in the keratometry. And if we look before and after, we see markedly different keratometric readings and axis and cylinder. And we saw a half diopter change in the IOL. So beware of the ocular surface. We have some means for accelerating these changes that are very useful, including the Procara. And if we look at the metrics here, just one per week, this is a very valuable procedure to the bottom line of the practice. There's a wide variety of other types of amniotic membrane. I find that the stability of this placed in the office well exceeds the expectations and is an improvement over the other varieties that seem to slip away under a standard bandage contact lens. We use the TopCon Synergy system to organize all of this information. You need one-stop shopping for all of the various anterior and posterior segment imaging that you require to manage your patients best. And in this era of electronic health records, efficiency is paramount to those of us who feel slowed down in the office clicking and pointing rather than talking directly to our patients. So if we combine the therapeutics revenue, we see that we've produced a very reasonable bottom line to the practice that must be managed very intelligently by motivated doctors who we compare on a monthly basis for those procedures that they're doing and for clinical results. We only utilize those that give us evidence-based medicine improvement in our patients' outcomes. So we can expand the product line, and we trace this doctor to doctor. We look at which doctor's doing the most retail sales, the best LASIK volume, the best premium IOL volume. If you can't measure it, you can't track it and change it. Very important. We are great proponents of hydro-eye, which contains both omega-3s and GLA. It comes in a twice-a-day dosage regimen. We did a prospective multi-center randomized study in patients with evaporative dry eye showing that the OSDI improved after 6 months on hydro-eye. We did staining in Dr. Flugfelder's lab looking at expression of inflammatory cell surface markers, and we saw that the HLA-DR and the CD11 stabilized with the omega-3 supplement, whereas that continuous aging inflammatory process continued without that intervention. Simply delaying the aging process produced very valuable information for our patients and our colleagues in this first prospective analysis, showing statistically significant results in a dry eye population. We expand our diagnostic testing as well. We use osmolarity for virtually everyone who walks in the door. This is the foundation of our testing. We look at new dry eye patients, new surgical patients, punctal plug decision analysis, post-LASIK hyperesthesia syndrome, and a wide variety of patients who have what may be symptomatically disproportionate ocular surface disease. So if we look at the 12 docs and our patients and our practice in 5 locations and make a prediction based on volume, more volume from cornea specialists than others, we look at about 50,000 tests per year in our practice, which generates a certain amount of income. This is highly variable based upon insurance plans, and you have to be very careful to negotiate these contracts with each individual carrier or you will get burned. And you have to be careful about bundling and coupling those procedures that may have the same diagnostic code you will get 50% less for the second procedure if it's a plug or an osmolarity or an MMP9. And the MMP9 is a useful indicator of ocular surface inflammation. And here's a kid with an acute bilateral red eye, a pink eye. He's got preauricular lymphadenopathy. These patients with adenovirus may develop scarring in the conjunctiva, central infiltrates. I know pediatricians who've had to retire because of the keratopathy in this disease. You must have the Adeno Plus in your office. It's key to making that diagnosis. It's by far the best means we have of telling this patient they have to stay at home for 10 days while they remain contagious. Don't be the person who creates an epidemic in your office. The #1 cause of epidemics of EKC is not the Sheppard anymore, it's the eye care provider's office. And of course, the ubiquitous anterior and posterior blepharitis remain a great concern to us all, not only because of chronic recalcitrant ocular surface disease and dry eye, but because of the potential for infections. So we use LipiView and now LipiScan in all our locations, and we find that this can produce valuable diagnostic and consultative information for the patient who requires intervention with the LipiFlow device. And we use the DMI in a cash pay situation and a imaging pay situation, depending on the patient. Very valuable adjunct to this diagnostic group of conditions. So we look at allergic conjunctivitis, common in kids, common in adults. This is the forgotten ocular surface disease. And yet now with Doctor's Allergy Formula, you can perform this testing in your office. And I promise you, it's well compensated, it's easy to set up. ENTs, pediatricians, allergists have been doing this test for years in your community. There's no needles, the staff does the whole thing, our optometrist does the reading, we sign off, and we tailor preventative medicine for this patient. You can reduce medications that way. We know that we get better results with LASIK, for instance, when the patient's allergies are controlled. And this is a good income source for the office. It's very convenient for patients. You mean I can do this here, doc? Yes, they're very pleased to have that in the ophthalmologist's office because after all, the #1 symptom in the allergy population is ocular itching nationwide. So we can grow our practice through insurance and cash-based remuneration. We can use value-added services, and we must, of course, increase patient acquisition, top-line growth. And the best way to do that is warm market. Put brochures in the clinic. Talk to the family member who brought your patient in. Friends and family, internet, direct contact is your most cost-effective marketing. But look at insurance-based business, Cigna, for example. You get a mere $38, but you can increase by over 200% your income at that visit by doing proper diagnostic testing and giving them the right intervention based upon inflammation or hyperosmolarity. After all, the most valuable asset in your practice is doctor-provider time, and you must make the best use of it. For instance, a routine cataract per minute may generate $40 per minute for your cataract surgeon. But if you look at plugs, it may become even more valuable. A pro-care time is very minimal, and a toric IOL, of course, is extremely valuable to the patient who rids themselves of glasses and to your practice and to your doctor's ability to restore glasses-free vision. Similarly, if we look at cash-based procedures, we see that a bleph can be valuable, Botox is valuable, but LASIK and LipiFlow are at the top of the list for best utilization of your provider time. So if we combine the diagnostic collections, we get a certain total, and we combine this with the dry eye and therapeutic collections, we have a tremendous increase in the bottom line of our practice, which we trace. And that number is the equivalent of 3 good medical providers, 3 good optometrists or medical ophthalmologists. And we look at the way we save this pharmacoeconomic analysis towards societal benefit. And if you look at the reduced numbers of visits, the reduced guesses at therapy, random therapy, empirical therapy, OTC therapy, gasoline, work missed, we have a net savings in this pharmacoeconomic analysis of over $1 million to society because we're doing it right, we're getting it right the first time, we're using our analytical skills like an internal medicine specialist to deliver the best, most appropriate care to our patients. So how do you execute a dry eye center of excellence? You must have a doctor champion, someone to whom the other providers in your practice look up to for appropriate and very excellent application of these principles. You need leadership and engaged administration. Everybody in your practice must know where to send a dry eye patient, a LASIK patient, a Botox patient, and a premium IOL patient. And you use internal as opposed to external marketing. So the patients win with diagnostic accuracy. The payers win because you have targeted therapy, fewer visits, fewer random medications. And the providers win because of practice growth, and the practice wins because of income diversification. Everybody's happy, everybody wins. This is good medicine. It's not, here's 3 artificial tears, I'll see you in 6 months. This is the way we like to proceed. So this raises a lot of questions for you and your practice. How do we execute this? How do we make the best possible decisions for our patients? And you will see from the outstanding panelists here how they handle their particular situations in Georgia, in Seattle, in New York, and in North Carolina. We'd like to thank our sponsors, Alcon, Allergan, Biotissue, NovaBase, Science-Based Health, Shire, Tier Science, Tier Lab, and those particular folks who have done their best to bring this space together. All boats will rise with the tide. Everybody in the diagnostic, pharmaceutical, and therapeutic space in dry eye will benefit from this improved information, a lack of bad information. We don't want to speak badly of anybody in this space, and we want to promote growth of the dry eye. Population, the surgical population, and the providers who enjoy delivering this care for the first time in decades.